So I want to thank you, Alex, and also Migraine Canada for inviting me tonight to give you this chat about acute and abortive treatment options. And so just as a quick overview for those who are kind of new to the migraine world, we kind of think broadly of medications for migraine in two main strokes. You've either got preventive options, which are what you take every day to try to stave off a headache, or you've got acute or abortive ones, which are the ones you might take as PRN or on an as-needed basis. So we're going to focus on the as-needed medicines. And everybody knows the common stuff, but I have some kind of unusual ones that I've been collecting from my friends abroad. So it's nice to just kind of get an idea of some other ones you might be able to try. So, I think it's just frozen. So my name is Alex Melinyshyn. I'm a neurologist and a headache specialist, and I run a headache medicine practice in London, Ontario. So I'd say about 95% of my practice is dedicated to headache with a little bit of epilepsy, brain tumors, MS, that kind of thing. But I'm very interested about migraine because it runs deeply in my family. And, you know, my other interests within the headache world extend to things like cluster headache, psilocybin and cannabinoid research. So it's a very exciting time for headache because we have all these new treatments after having decades of relative quiet, you know, on the medication front. So I'm happy to kind of share these new updates with you. For disclosures, just so you're aware, I do work with a lot of these drug companies as they start to develop and analyze their data and kind of share it to the market. And so I'm often participating in advisory boards for companies like Novartis, Lilly, Teva, Lundbeck, and AbbVie, as well as I give speaker talks to various groups, whether it's pharmacists, nurse practitioners, family doctors, other neurologists. You know, I try to spread the gospel about migraine to make sure as many of us are on the same page trying to help other people with headache. So for tonight, what we're going to talk about is picking a migraine abortive. We're also going to cover some of the special considerations for groups of people that traditionally don't have a lot of options. This would be the elderly, you know, technically people over 65, although for neurology, I think 85 plus is elderly for me, and the pregnant and those who have cardiovascular risk factors, whether that's, you know, vascular disease, angina, hypertension, cholesterol, diabetes. When you have enough of them, we start to get a little bit concerned about some of the medicines. For acute treatments, we're going to cover NSAIDs and triptans. I think most people with migraine are familiar with the two main categories we would consider. Suvex and Cambia are kind of new versions of old friends that are formulated in a much better way and may provide you some extra benefit if you haven't had the chance to try them yet. One option that's gaining a lot of popularity, especially south of the border, is Timolol eye drops. These are a beta blocker eye drop that you can use in an acute fashion. And it's a really interesting option for those who fail to respond to conventional things or can't take those medications for whatever reason. And then I want to introduce you to a new class of medications called the gpants. If you've been going through the Migraine Canada forums, you're probably already familiar with them and their imminent release here in Canada. But they're very interesting because they're similar to the CGRP antibodies you may have heard about, but depending on which one, it can be used as a preventive or as an acute medication. So it's really changing the way we think about our medicines for migraine. Another disclaimer here is that some of the information included in this presentation, it references products which are approved in the States under FDA, but have yet to be officially approved by Health Canada. So until we get that official last seal, you know, we have to warn you that the safety and efficacy of these products is not established and still being investigated. So if we're coming across something unusual like this, mostly the gpants in this case, you're going to see a little caution sign that I stuck in the corner. So I wanted to show you our Canadian Headache Society guidelines for acute treatment. These are dating back a while now, 2013, which is like back when I graduated from medical school. So, you know, they're a little bit out of date now. And I know Suzanne Christie is working very hard with her group in Ottawa to update both the acute and preventive guidelines. So the problem is every time you turn around, we got a couple new options coming up. So it's constantly updating. In this, I just wanted to highlight some of the more popular options that you can consider. I would say, like we talked about, the mainstays are two main categories, the NSAIDs and the triptans. Of the triptans, I would say probably the best bang for your buck from a money perspective and efficacy is going to be something like rizatriptan, sumatriptan, or elatriptan. And every doctor kind of has their own voodoo about how they select them. The triptans are a bit of a rainbow. There's about 7 of them. They all have slightly different pharmacokinetics, which means they may take different amounts of time to peak in your blood, to absorb them, to linger in the blood for a while. And some of them can be taken as a pill orally, as a nasal spray, or as a needle. So depending on which one you're using, they have slightly different profiles. The NSAIDs, on the other hand, I would say the mainstay of this one is naproxen. And it's a cheap old medicine, and it's cost effective. It works very well. Diclofenac is another cousin nonsteroidal anti-inflammatory. And this one, if it's done in the right preparation as a potassium salt in an effervescent form, is actually the fastest in onset of action. And we'll cover that in a second. Just to be aware of the contraindications, we'll go more into depth in these in the future. But for triptans, anybody who had a history of coronary artery disease, stroke, mini stroke, heart attack, angina, any kind of blood vessel disease, including Raynaud's, you really were contraindicated from taking this. They're excluded from the trials, and because they constrict blood vessels, the thinking is like this might produce, vasoconstriction and a ischemic event in people who are vulnerable. In pregnancy, they're considered category C, which is kind of like an unknown kind of gray status. But I'll give you some pearls later on that maybe would suggest it's probably safer to use in this context. So you might want to take a screenshot of this one. These are my favorite acute medications. And like I mentioned, every doctor kind of has their own bag of tricks. For NSAIDs, I usually start with the cheap stuff, naproxen, 500. You can take it as a leave over the counter, but this is only 220 milligrams. I would say it can be safely used by most people, 500 milligrams up to twice a day, no more than 15 days per month. And that really is the upper limit of that medication overuse headache. Beyond that, you're going to run the risk of developing kind of a rebound or withdrawal type headache, which we call medication overuse headache. For those people who say, well, I really get terrible dyspepsia, I can't handle Advil even, I tend to offer them Nebumetone instead. And this was a pearl given to me by some of my mentors over at Women's College. And Nebumetone is like the ugly sister of the NSAID family. For some reason, she didn't get publicized well and didn't get a good shake from the advertisements. It's a lot slower to peak, but it does linger longer in the blood, and it doesn't cause as much gastric irritation. So I've had really good success with those patients who tend to be very sensitive in the stomach. So you can ask your doctor for that if that seems to be the case for you. The one I like to highlight today is Cambia, which you may have tried. It comes in a little white paper metal sachet, and you mix it into 2 ounces of water and stir it up. It is the fastest onset of action, but because it's about $10 or so per dose, it can be out of the reach for some. For the triptans, my favorite are rizatriptan, which is somewhere in the middle of that spectrum we're talking about. And for those who find it isn't strong enough, I tend to work it in a stepwise fashion. We'll jump up to sumatriptan, which is the eldest and sometimes the strongest. But the balance of that is it may have a little bit more side effects, chest tightness, tingling, a bit of drowsiness. For those who find rizatriptan too strong, I'll drop down to things like alma or naratriptan, which are ones that we often use in children and tend to be even better tolerated. The other pearl that I think, we always tell people treat early, but I think some patients misinterpret this, that if the headache is already brewing, it's too late and I shouldn't even bother taking my triptan. That's not true. Triptans are useful at any stage of the migraine, but the chance of it working and nipping it in the bud 100% very quickly kind of falls off, and the best chance to treat it is either during the aura or very early on in the onset. So treat early is the first pearl. The second one is combining the NSAID and the triptan. And so there are certain formulations you can buy, like Suvex, where this is already done for you, or you can actually take the separate prescriptions and put them together. What I emphasize for my patients is that the gestalt, or the sum of the parts, is greater than each individual. And so 1 + 1 = 3 kind of thing. So there's a lot of synergy between these medicines. They help each other absorb more rapidly and peak in the serum. And so taking it together, understandably, many people want to take as little medicine as possible, but it should be kept as a tool if you really aren't doing well with each agent alone. So don't forget your acute medications. Sometimes in a rush, doctors just focus on the prevention. And if you suffer with a migraine, I would say if there are no other contraindications to taking it, you should definitely try a triptan. It is a specific medication for migraine. And if you're on the fence, then they say probable migraine, or maybe it's a migraine, we don't really know. If it responds well to a triptan, that pretty much clinches the diagnosis. Contraindications include, like I said, coronary artery disease, which includes MI, or angina, a history of stroke or mini strokes, vascular disease, uncontrolled high blood pressure, and also Raynaud's phenomenon. This is another thing that many people believe they have Raynaud's, when in fact they just have poor circulation, and we live in Canada and they're not wearing gloves. So I will actually sit down with patients and show them all the pictures on Google of Raynaud's phenomenon with the digital pallor, which is the areas of white digits on the knuckles and things like that, the libido reticularis and everything associated with Raynaud's. And they'll say, well, actually, no, I don't have that at all. My fingers just go a little bit pale and cold. And so I think that's the difference. If there's any question at all, and you think you may have an inflammatory connective tissue or autoimmune disorder, and you think you have Raynaud's, I would say it's worth a shot to go see the rheumatologist and have them confirm it for you. You may need to try more than one triptan before you find the one that fits you. And this is kind of unusual because we think of the chemistry of them as all being relatively similar and comparable, but that's not the case. They all have different pharmacokinetics, and sometimes it really does take a trial of a few of them to find one that you tolerate very well and that works very well for you. We talked about treating it early. The other point is that you can take a second dose. So some people don't always follow up quick enough. Sometime within 2 to 4 hours, if you're not feeling any better or you think you can do better, you can repeat a second dose, both of your triptan and of your NSAID. The limits for the medication overuse headache, I hammer home with my patients every time we talk and meet together. They know I'm kind of flogging a horse here that doesn't require it, but it's fewer than 15 days monthly for the simple stuff. And that's, Advil, Tylenol, naproxen, your NSAIDs. For the harder things, and this includes categories like opioids, which personally I avoid in my practice unless you're palliative for a brain tumor or really you can't take any other medicine. Triptans, butalbital containing compounds, which is like the ancient Fiorinol that we're all trying to get everybody off of. These ones really have to be used with caution. The official limit is 10 days per month, but some studies show that butalbital and opioid containing compounds as little as 3 to 6 days per month may toss them into overuse headache. So let's start with Cambia. Like I mentioned, it's diclofenac potassium. It's a fine powder. You mix it into 2 ounces of water, which is a really tiny amount. And it's kind of nice because you can knock it back quickly and it's not everybody's favorite flavor. It's a combination of mint and anise to mask the bitterness of the medicine. So some people love it, other people not so much. And the good news is that it is very effective as an abortive. And so it peaks within the blood within 15 minutes and has very rapid absorption. Doesn't seem to matter whether you take it with food or not. And I want to show you a graph here to compare the diclofenac tablet, the exact same medicine. And sometimes the pharmacist will say, oh, don't worry, a cheap version is you can get a tablet and grind it up and mix it with water and it does the same thing. That is not true. It is not a potassium salt. And so the potassium and sodium salts are absorbed differentially. And also this is a special effervescent preparation that facilitates that absorption. So I would caution that it really is not the same thing and that really Cambia in this instance is superior. So we get measurable plasma levels in 5 minutes, peak plasma levels in 15 minutes. Food does not absorb the time to maximum serum levels. And just to show you kind of the relative comparison to the cousins, Cambia is peaking there somewhere around 15 minutes, while your other NSAIDs like ibuprofen and naproxen are taking an hour and beyond to get up to those levels. For a comparison between Cambia and the triptans, things like sumatriptan subcutaneous, the SC, this one is going directly by needle under your skin, but as you can imagine, not many patients want to go that route every time they have a migraine. There's a significant delay between the time to Tmax, which is the peak levels in your blood. So really, Cambia represents an option to treat early those headaches where you wake up with them from sleep, or the really fast onset, or you just need immediate relief. So these are kind of the indications, which would be fast-acting attacks, present on awakening, or if you have early nausea, photosensitivity, or things like that. So there was an impact study, which was kind of their pivotal trial. They included adult patients with a history of migraine with or without aura, and they only really excluded those who were unable to perform the whole protocol or were completely debilitated during their headaches, which would render them unable to actually prepare the Cambia. So they treated one moderate or severe attack, and 807 points were captured in this. And their primary endpoint was to look at the number or percentage of people at 2 hours who were saying, I've got no pain, no nausea, no photophobia. So at 2 hours, pain freedom happened in roughly a quarter of patients compared to 10% with placebo. Just to give you a relative, you can't really compare apples to oranges, but in a similar meta-analysis of triptan, perhaps they were pain-free at 2 hours, 29%. For nausea, light and sound sensitivity, looking at the freedom of this at 2 hours, Cambia showed significant statistical and clinical improvements compared to placebo. Looking at the adverse events that they encountered in this trial, there were not a lot of significant divergences from placebo, maybe a little bit of extra vomiting or nausea. And apart from that, like it wasn't really well tolerated or poorly tolerated from a dyspepsia perspective, which is what sometimes you'll hear people say that it causes some stomach irritation. So from the Canadian Headache Society, it recommends Cambia offers a rapid onset of action as early as 15 minutes, and that it should be considered as the first choice prescription for the acute treatment of migraine attacks of all severities. The main issue here is the cost, because sometimes it is difficult to get it covered, and it may be $8 to $10 per dose. Sometimes, even with a good NSAID like Cambia, it just isn't enough to treat your migraines, and you need to use more than one mechanism. So that's where Suvexx comes in. We had already talked a little bit earlier about combining your medicines. And so this formulation contains both sumatriptan and naproxen, but it's not the traditional sumatriptan you think. It's an RT formulation. And so it's also co-absorbed with naproxen in such a way that they needed to reduce the milligrams of it. You don't need the full 100. So it's indicated for the acute treatment of migraine with or without aura. Recommended dose is to have 1 tablet, and you can repeat it 2 to 4 hours later if you still need to, maximum for 2 tabs per day. So it acts on multiple mechanisms in migraine, and I think that's why it's more successful than either agent alone. So the triptan, it prevents or reverses the vasodilatation, which we think of more as an epiphenomenon of migraine and not the cause of the pain itself. It inhibits the release of CGRP and other inflammatory soup that comes out of the trigeminal vascular system during the migraine attack. And it also helps to prevent central sensitization and inhibits the way that we process and transmit pain in the brainstem. Naproxen, on the other hand, it addresses peripheral mechanisms of nervous sensitization by inhibiting prostaglandin synthesis and creating an anti-inflammatory effect. It also prevents central sensitization, and there's evidence that over time it may even reverse some of that coming out of other pain literature. So it really is a unique formulation because it disintegrates very quickly and disperses, and it's able to kind of get around the slowing of the gut that occurs from migraine. And that's actually, we think, the basis of the nausea that many experience. So looking at some pivotal trials for this one, there are actually 2 that they repeated to be doubly sure. And they were primarily looking at pain relief at 2 hours. And so these were placebo-controlled single attack studies. And so they were also allowed to take rescue medication anytime 2 hours post-study drug, just so that they weren't, torturing them during this trial, but many did not need to. So compared to placebo, Suvexx also achieved significant decreases in light and sound sensitivity and nausea 2 hours after dosing. Looking at the adverse events, there were no new safety findings for Suvexx compared to each individual component alone. So nothing new from this formulation that makes you think it's more dangerous than either sumatriptan or naproxen alone. So in summary about Suvexx, it's a combination superior to either medicine given alone. If you put them together, the size of the effect is greater than either agent. And that's why I want to hammer this home for you. Early intervention results are improved for both 2 hours and 2 to 24-hour pain-free response. Onset of action, about 30 minutes. So a little slower than Cambia, but still a good effect size. And it has reliable 2-hour and sustained pain-free response. And so many people did not need to take a second dose of anything. Most of those who are pain-free at 2 hours remain pain-free at 24 hours. So for those of you who are concerned about rebound, like, oh, I'm going to feel fine tonight, and I'm going to wake up again with this migraine. This medication tends to avoid that. And it may enhance patient compliance because, like I mentioned, I don't blame my patients. Most of them don't want to take extra medicine if they don't have to. And so some may not feel comfortable combining it, even when, we give them reassurance. The next one I want to talk to you about are the Timolol drops. And this one is kind of like an under the radar, those in the know kind of are gaining traction with this idea. So we use Timolol maleate of 0.5%, and you put one drop in each eye right at the onset of migraine, and then you can do it again 30 minutes later. This came out of a really fascinating observation. It was an ophthalmologist and his friend who also treat migraines, and they were talking about helping their daughter, and they had observed some cases where in treating glaucoma with these drops, patients reported a lot of improvement in their migraines. And then we get into like, well, is this really a migraine or is it a glaucoma attack? Who knows? But there's a lot of good rationale why this makes sense. So oral timolol, the pill, is FDA approved for migraine prophylaxis. They've done the trials on it, and it works like propranolol or metoprolol or other ones from the same family. The issue with the oral is that it's kind of gradually absorbed through the stomach, like the other medicines, and first pass metabolism. So when you drain the whole bowel and stomach as it absorbs food, it all goes through the liver first. And you're going to lose a portion of that drug before it even gets back to the circulation. So you're kind of taking a little tax there. The ophthalmic drops, on the other hand, it bypasses that directly into the systemic circulation by being absorbed through cornea and the blood vessels of the eye. So it also goes in through lacrimal duct into the nasopharyngeal mucosa, and to a lesser extent, it's absorbed through the conjunctival epithelium around your eye and into the GI tract from there. The maximum plasma concentration peaks within 10 to 15 minutes, so very rapid onset. And what's interesting is that one drop of this results in a plasma concentration of 2 nanograms per mil within that time frame. And it blocks beta 1 and beta 2 receptors about 80% with that plasma concentration. So significant therapeutic serum amounts can enter the bloodstream through the eyes. So this is a very interesting finding. So we have a randomized crossover placebo-controlled pilot study. They were looking at Timolol eye drops as an abortive treatment for migraine. And participants were recruited out of Kansas City neurology and ophthalmology clinics. They also posted some flyers around the hospitals and clinics. They included any men or women over 18 who had a good diagnosis of migraine by ICHD3. And then they gave them screening, neuro, and eye exams. These people who passed the screening were then randomized 1-to-1 to either get Timolol eye drops, as we mentioned with that dose, or artificial tears, which are just saline. And they were doing one drop in both eyes at onset and 30 minutes after. The participants were followed for 5 visits over 4 months, so a month between each visit, and crossed over at the 2-month mark. So at that point, they're given a 3-day washout period where they take no drops, and then they switch over, and they still don't know they're blinded at this point. The participants rated their migraine attacks on a scale of 0 to 3 in terms of severity, and at the end of the study, they were asked to rate the effectiveness of their drops on a scale of 1 to 4. So in the course of this study, almost 200 separate migraine attacks were studied among 10 different individuals, and they rated the effectiveness Timolol as 2.4 as opposed to placebo 1.4. 4 participants with Timolol found it highly effective compared to placebo, and 1 found it the other way. They thought the placebo was much more effective. The average percentage of headaches with a severity of none or mild at 2 hours, Timolol was 78% versus placebo 57%. And you may be saying, well, look at the size of these placebo responses. What I would say is that pain is extremely psychological and expectation really does affect it. And if you look at any of our trials in migraine or other pain niches throughout the literature, placebo response can be quite significant. And so I think sometimes people feel like placebo means fake or it's not true, but it's a very valid and useful therapeutic tool. And I think we have to respect the size. For us to prove that a drug is useful, you just have to prove that it is in excess of the placebo. And I think we're starting to see some evidence here for Timolol, although the quality of this trial is limited by size and statistical significance. So they did some statistics to determine the validity of this finding, and they wanted to account for repeated measurements across time. The difference in this trial was not found to be significant. So we have these cutoffs of p-values, which determine whether or not the probability of a finding is attributed to chance alone. And really, the limitation of this is the sample size. If we can do a very large prospective controlled trial of this, this may be able to demonstrate the signal. But I will tell you, those who use these drops in clinic, they swear by them and they seem to be quite useful. What's nice is that, when we're taking this approach, we would say, well, we got to balance the risks and the benefits. Adverse events, one person had a branch retinal artery occlusion, which is a type of stroke in the back of the eye, and it was taking placebo, so it's really thought not to be related to the trial. No real other adverse events, including low blood pressure or slow heart, were observed during the trial. So in summary, you can use these 0.5 drops, 1 drop in each eye at the onset of migraine and 30 minutes later. Generally well tolerated with few side effects, even with daily use. However, they're not tolerated by everyone. And this goes back to Alex's warning about talking to your family doctor to see if it's appropriate for you. Some beta blockers can lower your blood pressure, slow the heart rate. Very rarely, they may have an adverse effect on asthma or a reactive airway disease. And in diabetics, if you're prone to hypoglycemia, the low blood sugar, it can mask the symptoms of this and it can lead you to trouble. So it's important to see with your healthcare team if it's appropriate for you. Next, we're going to jump to the pregnancy world. I think many women are rightfully concerned about taking medicines during conception, pregnancy, and lactation. It's a scary time, and you're making a really big investment in bringing a new life into the world. You want to give them the best chance they have. And for some women, that means they're willing to sacrifice all of their comfort. And so I would say it doesn't have to be that way. The purists want to stop all medicines except for their vitamins. But I would say many things have demonstrated significant safety and tolerability for migraine treatment. Paracetamol or Tylenol, acetaminophen, is probably the safest medication throughout pregnancy. It's considered safe across all phases. While sumatriptan, I would say most of us feel that enough safety data has accumulated through database research, looking at those who didn't know they were pregnant or were in such dire straits that they took it anyway. And there doesn't seem to be a significant safety concern there. Other medications I just want to highlight are NSAIDs. They are generally compatible with lactation, breastfeeding, but really I would avoid them, even though they say, okay, yeah, perhaps it could be used very safely in the second trimester. I generally advise all women to stop NSAIDs during their pregnancy. It carries a small risk of closing a little channel across the heart that the baby uses to breathe while it's in the amnion, the fluid. And this is so important because if you fuse it prematurely, the baby will suffocate and die in the womb. So it is critical to avoid these medications. So what can we use? I would say first-line treatments for migraine are usually non-pharmacological, and this means working on your sleep hygiene, doing good light exercises tolerated, nutritious meals, adequate hydration, and other formats that work are, biofeedback, relaxation training like deep breathing and body scanning. The preferred acute treatments when we do have to use them would be things like Tylenol, Gravol or diphenhydramine, and metoclopramide, Maxaran. Tylenol is really the safest option if you want to just stick to the bare bones, but sumatriptan is probably safe during pregnancy based on our accumulated data. Advil and other NSAIDs, like I mentioned, are to be avoided. So let's go quickly over the sumatriptan, naratriptan, Trexamet pregnancy registry. Trexamet is actually the American name for Suvex. And this was important to see long-term safety surveillance data and kind of give us our initial index of safety. And what it found was that no evidence of teratogenicity from preclinical studies of sumatriptan or naratriptan were reported. So this was the basis to start this registry. And sumatriptan has been assigned pregnancy category C. In this study, this registry, we had 626 pregnancy outcomes obtained from 617 pregnancies. So some of them obviously had more than one child related. And in the first trimester, there were 528 exposures, 474 live-born infants, 34 spontaneous losses, 15 induced abortions, 5 stillbirths. Of the kids that were born, there were 20 birth defects in total, 16 live-born infants, 1 stillborn, and 3 induced abortions. So for an average of birth defect of about 4.2%, with a confidence interval, based on our statistical analysis of 2.6 to 6.5%. In the second trimester, there were 78, 3 infants with birth defects. And in the third trimester, oh dear, kind of went out of order here. But what I wanted to show you here is that birth defects with any trimester of exposure are about 4.2% on average. And if you compare this with the general population, we have good estimates of this. And we think that in the United States in particular, about 1 in every 33 children, or about 3%, is born with a birth defect. And this falls well within the range of that confidence interval. And after a thorough statistical analysis, they did not think that any increased risk of congenital defect was observed. However, what I want to stress is that observational databases like these are insufficient to be conclusive. And so really, with limited data on the second and third trimesters, it really is a conversation that you have to have with each person and really weigh the risks and benefits and what they're willing to accept. So I would say it should only be given during pregnancy when the benefit outweighs the risk. We also have a cohort study here looking at pregnancy outcomes after triptan use. And this is a prospective observational cohort study. And what I wanted to highlight here was actually, sorry, I think we lost or cut off our thing here. But basically, it said the same thing, that no significant safety risk in terms of abortion or spontaneous fetal defects was observed. Next, we're going to talk about the cardiovascular risk factors. Just to recap, this is not an exhaustive list by any means, but I want to list the most common contraindications for why you would not take these drugs. For NSAIDs, especially if you're on anticoagulants like any of the warfarin or the newer ones like Xarelto or the 10A inhibitors, you're going to want to avoid these because they increase the risk of a fatal bleeding event or a serious bleeding event, whether it's into your bowel or into your head or elsewhere. If you've had bariatric surgery where they do like a Roux-en-Y bypass or some other type of procedure like that, an anastomosis, you may be at risk for significant complications if you continue to take NSAIDs. And so many people are forbidden from that. Other people include different types of ulcerative or inflammatory disease, whether it's peptic ulcers, IBD like Crohn's or ulcerative colitis, and also significant kidney disease, as NSAIDs with prolonged use can cause kidney damage. For the triptans, we've already covered it a couple times here, but I'll recap in brief. Coronary artery disease, stroke or mini stroke, vascular disease, including uncontrolled high blood pressure, Raynaud's phenomenon, and more. And there's an unfortunate group of people that fall in the Venn diagram of this. And, you know, for many of them, they feel very disheartened because they walk away from the doctor and they're saying, well, you know what, all I've got for you is Tylenol. So good luck to you. And that, I think, is the wrong message because there's so much more that you can offer them. So what can be used? Well, of course, there is Tylenol. For many of them, aspirin is an option unless you're on a blood thinner. Lasmiditan was a medicine that we were really hoping to see in Canada. And it's a cousin of the triptans called a ditan. And this one acts on a slightly different serotonin receptor, thought not to cause vasoconstriction. And it was going to be safe for use in these patients. However, at the last minute, Health Canada pulled approval because they couldn't agree on the labeling, and the manufacturer withdrew their application. Other options include non-invasive nerve stimulators, the Cephaly and the Gammacore, which I spoke about in a different talk for Migraine Canada, and we'll lead you there in the comments below. And the issue with those is that you cannot use if you have any other implanted devices. So, you know, that if you have a pacemaker or something, you're kind of forbidden from them. gpants, which we'll get to in a second, are a new class of acute medication that perhaps don't cause medication overuse headache and may be also safe to use in those with cardiovascular risk. And we talked about Timolol eye drops, which could be good, but also have to be used in caution if you have significant cardiac disease. Next up are the elderly. You know, I think there are many people who are a little white-knuckled with the triptans because the original trials did not include people over 65. And this is a problem. I mean, most of these people who have migraine, it's a fifth of the population, it continues on as they go through life. And so I would say for elders, what I counsel them is that naproxen and hydroxyzine are the most commonly used for individuals with migraine or tension. And certain rescue medicines that we normally consider for migraine, like triptans in the younger, have to be used with more caution because over time you accrue more vascular risk factors and there's a significant risk of stroke or coronary disease. Like I mentioned, there's a lack of robust data beyond the age of 65, but it has accrued, you know, in the same way that we got those pregnancy databases. What's important to note is that as you get older, your arteries harden, you develop trace diabetes and hypertension, cholesterol, all these things. and the risk of these events increases over time. So it's important to not just write a prescription for 3 years and walk away. Every time you go see your family doctor, it's prudent once a year to review all of your medicines. Absent any significant risk factors, I'm usually pretty safe to prescribe these for elders. I look in my practice and I think, okay, well, I have a 500-pound obese 33-year-old who doesn't walk and smokes every day. And then I have, an elder who runs for 2 hours every day and is 92, but, is fit as a fiddle. I think I would have more compunction about, prescribing a triptan for the first individual as opposed for this elder. So I think we have to think less about chronological age, look at physiologic age, and then the whole clinical picture. So risk for ischemic stroke and coronary heart disease associated with migraine and migraine medication among older adults. This was an interesting study analyzing over 35,000 Medicare beneficiaries through their EMR. And what they did was they found about 22,000 who had no history of cardiovascular disease and matched them to age controls, about 88,000 who did not have migraine or cardiovascular disease. Then they took a second arm and they took about 16,000 with a history of cardiovascular disease and migraine, and they matched them to 63,000 patients without migraine but with cardiovascular disease. So the patients with a history of migraine taking a triptan had a lower risk for coronary heart disease events versus those without a history of migraine. So in fact, it was perhaps protective. There was also no evidence of a difference in the risk of ischemic stroke compared to matched controls. So, really, it seems like it was safe in this group. The events occurred, of course, but when you compare it to a large cohort of people of the same age, relatively matched for their history of cardiac health, there wasn't an increased signal. Other devices that you could consider, and this goes back to that talk I gave previously with Migraine Canada, would be the Gamma Core or the Cephaly. These are the two that are available in Canada, and we don't have time to go into detail today, but you can see it in our other talk. Unfortunately, the eNeura and the Neurovio are not available in Canada at present, and I don't think there are plans to do so. So next up on our agenda is the gpants. So, we're joking amongst ourselves, like, I don't know how people name these medicines. I think somewhere they've chained a poor intern in the basement. They're throwing down Scrabble tiles to name these new medicines. So what is a gpant? It is a small molecule calcitonin gene-related peptide receptor antagonist. So that's a mouthful. Basically, if you're familiar with the monoclonal antibodies, CGRP is a chemical secreted from nerve endings that is pro-inflammatory, and it perpetuates that vicious migraine cycle. If you can block it, either the molecule or the keyhole that it fits into the receptor, you have a good chance of reducing migraines. So this one is an oral as opposed to the injected antibodies. And when we think about how CGRP plays a role in migraine, blocking it seems to block the neurogenic inflammation, it decreases the dilatation of arteries, and it inhibits pain transmission. I mean, this is kind of a simplistic overview, but I think it's a really good place to start. So what is CGRP? It's a really large neuropeptide, and it is the most abundant one in the trigeminal ganglion. It's located in both C and A delta nerve fibers, and it gets released with glutamate whenever you activate that trigeminal ganglion. The trigeminal ganglion and the trigeminal cervical complex is the area through the brainstem that we think not generates the migraine perhaps, but is the main highway through which we transmit and process pain for migraine. And so it has a lot of different functions all over the body, but luckily most of these are in parallel. So it's a redundant molecule, and blocking it doesn't seem to cause many side effects, except in migraine where it turns it off. So how did we start to think about this as a potential target even? There was a couple of really smart people who made some interesting observations about CGRP back in the 80s. And they noticed that levels in the blood were raised during a migraine, and these dropped when you gave them sumatriptan. In migraineurs, when they were in that premonitory phase where the headache is coming on, CGRP was up compared to when you look at just the interictal part where they have no headache. Interestingly, I don't know how they got ethics approval to do this. They took healthy controls with no migraine and infused large quantities of CGRP intravenously. And this was able to target, a significant headache. We also noted that there's increased levels of CGRP in chronic migraineurs as compared to episodic migraineurs. even higher than those controls who had no headache. So it seems to be dose dependent. Also, another researcher realized that, oh, increased levels of CGRP predicts response to Botox. So all of this evidence started accruing and people thought, well, what happens if we block it? So here come the new CGRP antagonists that you can take orally. Poised to come to Canada. Hopefully soon we'll have a brogepant somewhere between November to January. And then we will see arrival of atogepant and rimegepant. And they're all slightly different, but I highlighted a couple things here. Atogepant can be used as prevention for both episodic and chronic migraine. Ubrogepant is approved for acute treatment, and rimegepant can be used for acute treatment or prevention of episodic and chronic migraine. So it's really kind of blurring the paradigm that we talked about, those two broad strokes of treatment, acute and preventive. They all are receptor antagonists. They all are taken orally, and they're manufactured by various companies. Most importantly, they do not cause vasoconstriction like the triptans. There's no contraindications for use with patients with vascular disease, and thankfully, during the trials, no one observed any serious vascular events. Also important to highlight is that they're not thought to contribute to medication overuse headache. So this is a good option to give to patients who are currently overusing their acute strategies without blaming them. Another option is that this is good for the needle phobic, the patients who really don't want to administer a needle, and the thought of that is just terrifying to them. When should we be considering these for use? I think for me, anyone 18 or older with a confirmed migraine diagnosis, they have failed to respond to either NSAIDs or triptans, or they are contraindicated because of various medical conditions. For the sake of time today, I'm just going to present the data from these molecules in aggregate. But it's important to note you can never really make head-to-head comparisons of these trials, just because they're all slightly different in the way they design them, they measure the outcome, and so it really isn't fair to put them all together. Quickly about ubrogepant, it's an acute treatment. You take 50 or 100 milligrams as needed, and you can take a second dose at least 2 hours later. The maximum dose for 24 hours is 200 milligrams. And if you have hepatic or renal impairment, you're going to want to adjust the dose to 50 milligrams. It's well tolerated with side effects similar to placebo. The most common effects were nausea and dizziness. And if you're in the know about the research for these molecules, the very first one that came out, telcagepant, did have some fatal liver hepatotoxicity and elevations. They tweaked these molecules and they are particularly safe, and no significant liver signal was seen in the latest iterations. Rimegepant, on the other hand, is another medication. Safety of it more than 18 doses in a 30-day period is not established. And this is interesting because you can take it every other day as a preventive, okay? And then you top it up as needed on the days that you don't take it. So it's a little bit of a confusing algorithm, and they're actually repeating the trials looking at daily doses to get rid of that. Contraindications for this would just be hypersensitivity, like an allergy to a medication, which is the same for any medicine. And the safety profile was comparable to all the other CGRP antagonist trials. So looking at the data, these are the major pivotal trials for ubrogepant and rimegepant from an acute perspective. They were all very, very large and well designed, and they did this to obtain good statistical significance, which they all met their endpoints. Looking at 2-hour pain freedom, you can see that the difference versus placebo is I would say, clinically significant. However, when you're calculating the number needed to treat, this is the inverse of the difference versus placebo, the therapeutic gain. You may need to treat, somewhere between 10 up to 13 instances in order to get one good outcome. And so we'll talk a little bit more about that in a second. For 2-hour most bothersome symptom freedom, again, there's some gain versus placebo with the number needed to treat ranging somewhere between 8 to 12. So how do they measure up to the triptans? Like, is this drug worth your time? There is a comparison of the new pharmacologic agents against the triptans, a recent JAMA Open Network paper, and this included 64 randomized controlled trials. And what it found was that the 2-hour pain freedom, triptans were superior to gpants with an odds ratio somewhere between like 1.5 to 3.4. For pain freedom or pain relief at 2 hours after the dose, lasmiditan, rimegepant, and ubrogepant were associated with higher odd ratios of pain freedom compared to placebo, but lower compared to triptans. And you can see the values here on the left. comparisons between all the new agents themselves were not really significant. So, maybe they aren't as good as triptans up front. However, the lack of the cardiovascular risk for these new classes may offer an alternative to triptans for those who couldn't take them anyway. If we're looking to compare the numbers needed to treat, this was a good meta-analysis that looked at all of the triptans as well as the cost efficacy, if you want to delve deeper. And, so maybe frovatriptan is comparable to some of these newer ones. It has a higher number needed to treat, whereas the other triptans range somewhere between 3 to 4 or even up to 8. So frovatriptan is actually like the most costly, and I think it has some role for use in like perimenstrual prophylaxis and things like that. But I would say the bang for your buck, maybe looking at sumatriptan, rizatriptan, elatriptan. And as a general rule of thumb, I think when you're trying to understand the number needed to treat, like what it means to me is that you would need, like say the number needed to treat is 20. That means you would have to treat 20 instances using this drug before you have one good outcome that is not attributed to placebo or just the natural resolution of a migraine. So when you're factoring in cost, I think you really have to take it with a grain of salt. And I would say that, a general rule of thumb is the number needed to treat the 5. The FDA reviewed like the crude data from these trials and calculated, these numbers needed to treat for freedom. For rimegepant, 75 milligrams, 20, and for ubrogepant, somewhere around 10 to 15. The costs have yet to be determined in Canada, but they are pricey south of the border. I mean, the typical trend is that we do pay much less for our medications here, but you can see that a month's supply is somewhere around $1,000 American. So we'll have to see. The cost of a single tablet of a brand name triptan is somewhere between $13 and $18. And then typically the wholesale or generic versions are half to 3/4 cheaper. A quick shout out to lasmiditan. We mentioned earlier the Ditan that never was, and unfortunately we won't be getting it here in Canada. But I wanted to include it just because you may hear about it through some of the American channels. It met all of its endpoints as well, and the thought was that it was safe in those with cardiovascular issues, and it didn't really have a lot of significant cardiovascular adverse events, just a bit of dizziness. The problem with this one is that because of the sedation or drowsiness, you're advised not to drive your car for 8 hours after taking it. So in summary, NSAIDs and triptans remain the mainstays of acute management. Cambia, it offers a faster acting NSAID option. Suvexx improves adherence in combining the agents, and with its gestalt effect, gives you a bit more efficacy than you'd get from either alone. New migraine treatments have arrived to market, and there are many more in the works that are coming. So I think that should give hope to many migraineurs. And the CGRP molecule antagonists are effective, safe, and well tolerated, a good potential option for those who have failed to respond to triptans or NSAIDs or are contraindicated. For me, questions remain about the cost effectiveness and access in Canadian markets. So with that, I want to thank you very much for your attention and turn the table to some questions.